Hi again. Today I'm going to continue with a second lecture tied to Chapter 14, which covers abnormal psychology or clinical psychology. The focus of today's lecture is going to be on disorders of childhood. Specifically, what I want to cover in today's lecture will start with a review of some of the ideas of DSM-5, but focus primarily on how DSM-5 is organized and deals with disorders of childhood, in particular some of the developmental issues that are important in how we understand psychopathology in childhood. And then what I want to do is focus on two specific disorders of childhood, autism and ADHD. These are far and away not the only disorders of childhood, but these are two very prototypic and good disorders to review to give you a flavor of how the field of psychiatry and clinical psychology is trying to understand the developmental origins, the developmental course, and ultimately the treatment of these two very serious disorders of childhood. Within autism and ADHD, I'll start by reviewing the core features, look at the epidemiology, which is the statistical information about how prevalent it is, and then review some of the etiologic or causal models. That's going to be the agenda for today. Okay, let me start by reviewing a couple of points that I made yesterday when I was discussing DSM-4 and some of the reasons for the revision that led to DSM-5. One of the major criticisms of DSM-4 was that it was lacking in developmental considerations. In other words, it was not a document that reflected our understanding of the developmental origins of different disorders and how those disorders might progress across the lifespan. DSM-5 was developed in large measure to address some of these developmental concerns. And one of the first things to recall about DSM-5 is that its organization of the disorders follows a lifespan perspective. So DSM-5 begins by presenting the information that's pertinent to diagnoses that manifest early in life, then disorders that tend to be more prototypic of the adolescent period, young adulthood, and then disorders that might be present through adulthood and across the later years. Okay, a second point to understand about DSM-5 is essentially its philosophical belief about how to think about disorders of childhood. And one of the ideas that's built into DSM-5 is that psychopathology in children or in youth is what is largely thought to be a deviation from developmental norms. In other words, the pathology that we might see early in childhood or across childhood may reflect the delays or things that interfere with children's ability to develop and accomplish and reach certain developmental norms. A second point that DSM-5 does a much better job of than its predecessors is that each of the disorders includes a section that characterizes the developmental course of that particular disorder. So whether you're talking about depression, anxiety, autism, ADHD, the sections that are tied to each disorder include information about the age at which the typical symptoms are first visible or present, information about how those symptoms might differ at different ages, or how those might differ in terms of specific groups like males versus females, and to the extent that we know something about how those symptoms might unfold across a lifespan, that developmental section for each disorder addresses that issue. And one of the major features of the developmental section within each disorder is this attempt to paint a picture of what the developmental trajectory of that specific set of symptoms might be across the lifespan, so that we can understand the way in which an individual dealing with a particular disorder like depression, autism, ADHD, how those might unfold across the lifespan. DSM-5 also includes important information about risk factors and prognostic factors in its consideration of each of the different disorders. And what do I mean by risk factors? Risk factors, if you recall, are characteristics or vulnerabilities of the child or his or her environment that increase the likelihood of the development of a particular kind of disorder. So DSM-5 includes information about how we know temperament to be a factor for different kinds of disorders, or to the extent that we have information about particular kinds of genetic vulnerabilities, what role do genetic vulnerabilities play as risk factors in increasing the likelihood of developing certain kinds of psychopathology. There is also important information about the developmental context and the kinds of psychosocial contexts that children and adults are in that might increase the risk of developing a disorder. So, for instance, there is information about the role that poverty and criminal environments play in increasing the likelihood of, say, antisocial behavior problems among youth, or how low resourced environments in which there's a high level of poverty, how that increases the risk for substance abuse disorders. So information about the context and how that acts as a risk factor is also an important inclusion in DSM-5. The DSM-5 also includes important information about the long-term or prognostic outcomes or predictions that we might be able to make about how children and adults dealing with particular disorders might look like over time. And within that, it includes information about key periods of development where that risk of either symptoms getting worse or potentially improving, how those pictures and profiles change across development. Okay, now I want to begin my discussion about autism. And before I actually start to give you some information about autism, what I'd like you to do is to watch this video, this short 7-minute video that gives you a really good flavor of what it's like to be the parent of a child struggling with autism. I think it's a really good example of the kinds of symptoms that make up autism, but also it gives you, I think, a fairly emotional and up-close view of what it's like to be somebody who's supporting somebody who's dealing with autism. Okay, I hope you enjoyed that film. Let me start by saying that autism is one of the neurodevelopmental disorders, and this is one of the sections within DSM-5 where you see some of the earliest types of pathology and developmental disorders that might affect children. Autism is one of the neurodevelopmental disorders and includes other disorders that, such as intellectual disability, communication disorders, and also motor dysfunction. So what is autism? Autism is a complex developmental disability that we believe is the result of neurological conditions, neurological features of the child, both features that were developing prenatally but also postnatally, that are going to broadly impact the development of a child in some fundamental areas, in particular in social interaction and social communication areas. Okay, let me start by giving you an overview of what the core symptoms of autism are. We tend to think of autism as being a disorder that has a significant impact on children's ability to interact with others in social contexts as well as to communicate. And one of the things we've come to believe about autism is that at its core, fundamentally, it is a deficit of what we call theory of mind. And if you remember back to the chapter on developmental psychology, theory of mind and the acquisition of theory of mind reflects the human's capacity to take somebody else's perspective. And this is a critical social mechanism for relating to other people, for understanding to other people, and ultimately for the survival of our species. And one of the things that we believe about individuals who are dealing with autism is that they have failure of theory of mind, this failure to be both interested in and take the perspective or to even be aware of others. There's 3 central or core features of autism. The first is, from a symptom point of view, is qualitative impairment in social interaction. So deficits in how children and individuals with autism interact with other people. Second, a core symptom area is problems in communication, language and the ability to use language to communicate. In fact, probably half of all children with autism never acquire what we would consider to be useful speech or speech that's going to be helpful in social interactions. And the third major symptom domain of autism is what we call restricted patterns of behavior, restricted interests, and restricted activities. And one of the things we see with individuals with autism is a very rigid and narrow set of things that are of interest and appeal to them. And a lot of times this appears as stereotyped kinds of behaviors or stereotypic kinds of interests. Okay, so one of the first things to think about is when might these core symptoms of autism first be visible? And what is the developmental course of these symptoms, what are these core features of autism once they are visible? One of the things we've come to believe about autism is that it begins to emerge, or these symptoms begin to express themselves for the first time during the first 2 to 4 years of life. Certainly by the time a child reaches around 3 to 4, a diagnosis of autism is a fairly reliable, can be made fairly reliably. But in retrospect, what parents often say is that even in the first year of life, they begin to feel and sense that something isn't right, either in the way in which the child or the infant orients to them, the kind of interest the infant shows in their primary caregivers. So when parents recall the earlier months and years of their child's life, one of the things that they often report is that they really sense that their child was showing limited interest in them socially, limited interest in communicating with them. One of the things we also know is that autism occurs much more frequently in boys than it does in girls. In fact, the rate of autism in boys to girls is about 4 to 1. So 4 times as many boys are going to be diagnosed with autism as will girls. However, one of the things that we've also come to understand is that autism in girls tends to be of a more severe kind, with the mild and moderate types of autism often being more characteristic of males, but more severe kinds of autism being characteristic of girls. One of the reasons why autism sometimes isn't clearly diagnosed until children reach about ages 3 or 4 is that for the first year and sometimes first 24 months of life, some children with autism will show normal kinds of development. They will acquire certain developmental skills at the age that you might expect them to. So there might be early babbling and early kinds of verbal sounds that suggest this child is developing a communication capacity. But one of the sad things about autism is that at some point there's going to be regression or either a failure to advance in those developmental domains. So whereas children might early on be showing that they're capable of certain kinds of verbal communication, after around 12 to 18 months, many of these children will begin, especially if they've got more moderate to severe kinds of autism, will show no gains in social and communicative skills. Okay, I mentioned that autism occurs in boys much more frequently than girls at a ratio of about 4 to 1. But what is the general epidemiology of autism? And this is a hotly contested area of the science today, and it's worth spending a few minutes thinking about. So, as you can see from this graph, about 4 million children every year are born, and of those, 500,000 are going to be diagnosed with some kind of developmental disability. Of these, quite a few, a large number, are going to be children who have been diagnosed with autism. And again, we're going to likely see the ratio of about 4 to 1 boys to girls be diagnosed with autism. Many of the children who will be diagnosed with autism, especially children in that moderate to more severe range, will also be diagnosed with secondary kinds of diagnoses, in particular intellectual disabilities. Many children dealing with moderate to more severe forms of autism will also be diagnosed with intellectual deficits of a very profound type and level. Oftentimes with children with mild to moderate levels of autism, some amount of school mainstreaming is possible, but when children are also dealing with intellectual deficits and significant disabilities, mainstreaming children with autism sometimes is impossible. Now, this next graph or slide has quite a bit of information, and it's presented in a fairly interesting way. And what I'd ask you to do is take a minute or two to study this slide and get a picture in your mind of what we know to be the prevalence or the epidemiology of autism. And in particular, I want to call your attention to information on this slide that is suggesting that we're seeing an increase in the incidence or prevalence of autism as we move forward in time. So as you just seen on this previous slide that's providing information, this next slide is giving you an even starker picture of what we think to be the increasing incidence of autism. And here's the rate of children in the general population in 2007, 9, and 13 who are diagnosed with autism. So one of the things we've seen is a steady uptick, an alarming uptick in the number of children diagnosed with autism, to the point that The Center for Disease Control, the CDC, now estimates that roughly 1 in 50 children might be born with autism. And this has really given us great concern and great pause in terms of trying to understand not just what are the origins or the factors that increase the likelihood of autism, but really what autism is. So, as we've seen the numbers of children with autism increase dramatically from 1 in 150 in 2007 to 1 in 50 in 2013, this has led a lot of scientists, a lot of parents, a lot of policymakers to ask, are we dealing with some kind of underlying autism epidemic? Why are more children being diagnosed with autism? And this is a very important question, and there are a lot of potential answers to this question. So what are some of those potential answers? Well, probably the major factor contributing to the appearance of or the increase in the number of children diagnosed with autism is greater awareness within the general public of what autism is. There's been lots of public campaigns, public policy campaigns, public health campaigns to increase awareness of what autism is. So we have generally a more informed population. So what might be some of the factors that are explaining the increase in the prevalence or the apparent prevalence of autism? Well, probably one of the most important factors contributing to this increase is increased awareness of what constitutes autism. In the last 20 years, there's been a lot of public service campaigns with the goal of educating both parents and the community, school districts, teachers about what autism is. So with this greater knowledge has come the ability, improved ability to spot autism when it is present. So it might not be that there's an increase in the incidence of it per se, but rather an increase or an improvement in people's ability to spot it. We've also seen other important changes in factors such as school eligibility. So now children who have autism tend to be eligible within school districts for certain kinds of additional support, whereas children with other kinds of intellectual and developmental disabilities tend to be less supported. So there may be a push to diagnose children with autism versus some other kind of disability because there may be added treatment benefits that accrue to families because of this diagnosis. All right, let's switch now to thinking about what some of the causal or etiologic factors are. And as with any of the disorders that you might read about in Chapter 14 or that we might cover in these 2 lectures on disorders, we would like to look at, or we should consider, genetic factors and what role they play in the causal onset of disorders. What are some of the brain characteristics that have been related to this disorder? Where can we look to the environment? What about children's environments might be producing or contributing to the development of different kinds of disorders? But ultimately, we really want to understand how do these biological and neurobiological characteristics interact with early environmental features to contribute to the onset of these different pathologies. So looking first at genetics, in particular behavioral genetics, one of the pictures that's become very clear about autism is that it tends to run in families. So we have strong estimates of heritability, especially in monozygotic twins. So children who are identical twins, if one of the children is diagnosed with autism, there's better than a 50% chance that the identical twin will be diagnosed with autism. In fact, some estimates suggest that almost 9 out of 10 of the identical twins will also be diagnosed with autism. When children are dizygotic or fraternal twins, the estimate decreases significantly. In fact, the likelihood that a fraternal twin will develop autism tends to be less than 10% in most studies. So this really gives us some sense that there must be some underlying genetic factor that's contributing to autism. So behavioral genetics studies have helped us to believe that there's a strong genetic basis for autism, especially among first-degree family relatives, but molecular genetic research has been much less consistent in terms of identifying which particular genes might be implicated in depression. At this point, it's probably safest to say that we know, as in the case of most pathologies, both for children and adults, no single gene is going to be causal in the onset of autism, but rather it's going to be complex genetic networks that are interacting together. But at this point, we've seen across many different research studies, very a diverse set of candidate genes interacting with one another. So our understanding of what the molecular genetics of autism is today is still very much in its infancy. We've probably gotten a lot more mileage out of research that's trying to understand the role that brain and brain processes plays in autism. And some of the best research to date has looked at structural aspects of the brain. And perhaps one of the most replicated findings has suggested that there's something about the size of children's brains who develop autism that may be abnormal. In fact, one of the findings that was done by the Piven Group in 1995 suggested that children who are diagnosed with autism often have heads that are 2 and 2.5 standard deviations bigger than what is considered normal. So it's these larger brains that might be carrying with them the risk for developing autism. One of the features of an enlarged brain is that it may lead to an excess of neuronal development early in development and greater inefficiencies in things like language and in social interaction. But as well, we've also found that larger brains sometimes also show less efficient what we call neuropruning, so a reduction in this excess and needless excess of certain kinds of neural connections. So the structure of the brain has been one area that's been studied in terms of autism, but what about functional areas of the brain? What about how the brain actually functions separate from size? And again, we've found very inconsistent results looking at brain functioning research. But one of the interesting findings that we think is related to theory of mind is we have found that there's differences in brain activation patterns of children with and without autism when they're presented with certain kinds of face stimuli. So imagine children lying in MRI scanners and being presented with images of faces, and one of the things we're seeing is very different activation patterns in terms of not just what areas of the brain activate, but the intensity with which these brain areas activate in children with and without autism. So let me see if I can make this neuroimaging finding a little bit clearer. So what you see here is a picture of a male face, and what I've imposed on this face is a series of lines that have been generated through eye tracking technologies, and what those lines correspond with is where does somebody without autism look when they first encounter this face. And what you see here is that the eyes and the dark lines or the squiggly lines represent where the eyes of somebody is looking when they're seeing this face. And really what you see is those eyes essentially, and the brain that's controlling those eyes is attending to the eyes, the nose, and the mouth region of this individual. This is where we look to get information about what this person is thinking and feeling, and it gives us some clue as to who this social partner might be. Now look at this face, this second face, or the same face, and what I've imposed over it is eye tracking data that pertains to where a child with autism looks when they encounter this face for the first time. And what you see is a very different pattern, and in fact what you see is an aversion of or an avoidance of that central face area. So you don't see very much eye tracking data that suggests the child with autism is looking to the eyes, the nose, and the mouth region, but rather what you see is eye tracking data that suggests the child is looking everywhere but there. And this may be neural characteristic of brains that are dealing with autism in terms of what might be interfering with some of their social and communication deficits. Okay, in addition to brain structure and brain function, one of the other critical areas in neuroscience is to understand the role that neurotransmitters play, and work that's been done on the neurotransmission in autism is no exception. One of the things we found is that there seems to be increased serotonin levels, which you know from earlier work is related to mood and mood regulation. So this excess of serotonin seems to be associated with children with autism, but at this point we don't quite know why that might be and what role that might be playing in terms of autism symptoms. We've also found alterations in dopaminergic neurotransmission, and we know that dopamine is related to behavioral profiles, and it might be linked to some of the stereotyped and repetitive behaviors we see in children with autism, but dopamine work has been somewhat limited. So as with structure and function, the work on neurotransmission in autism is still very much in its early stages. All right, let's shift from underlying biology to thinking about the environment in which children with autism develop. For many years, there was a belief that autism is the result of what was called frigid parenting, that children who showed this disinterest in communicating and interacting with social others must be children who were born to and raised by parents who treated them similarly, or what was called frigid parenting. I'm happy to report that there's no evidence of a role for such kinds of psychological and social factors. Rather, one of the things that's become clear is that in families where a child is dealing with autism, some of the difficulties that we might see in parent-child interactions or caregiver-child interactions may be a response to autism and not a causal factor. So it's unlikely that parent-child relationship processes are contributing causally to autism. But one of the things that has become clear, what has emerged in the research literature, is that there are aspects of what parents are doing, in particular mothers, in terms of prenatal and postnatal health, that might be showing associations with the increased incidence of autism. So one of the things that we've begun to know is that as women are older and older now, in terms of the age at which they conceive, there seems to be a positive correlation between the age at which women conceive and the likelihood or increased likelihood of autism. So especially among women who are older than 35 when they conceive, there seems to be some association with this more advanced maternal age and autism. We also know that prenatal complications like bleeding, vaginal bleeding during the first trimester in particular, has been found to be associated with autism. So there may be something associated with the trauma related to that prenatal bleed and some effect on the developing brain. But before I go on, it's worth saying that, like the work on some of the underlying biology, a lot of the work that's focused on environmental, parental, and pre- and postnatal factors has been largely inconclusive, or at least been very difficult to replicate at this point. So we're still very early on in trying to understand the causes. One of the controversies that dominated the field of autism for quite some time in the late 90s and early 2000s was the potential link between vaccinations and autism. Some of you may recall that for a number of years it was felt that the MMR vaccine, the measles, mumps, rubella vaccine that most children in this country get, may actually be contributing to the incidence of autism. There was a paper published in The Lancet, the British medical journal, published in the late 90s, that established or suggested that there was a causal link between the MMR vaccine and autism, and this led to a large public outcry about the vaccine and what might be a part of that vaccine that was contributing to the increase in autism. So once this Lancet paper was published, there was a very fast effort to understand what might be going on with these vaccines, what it is about the vaccines themselves and their properties, or how those vaccines are interacting with children's biology that might be contributing to autism. And one of the first things that we focused on was the fact that MMR vaccines, like a number of vaccines, are preserved with a mercury-based preservative called thimerosal. And so immediately the FDA and other drug regulatory agencies around the world essentially required that all preservatives or mercury-based preservatives be removed from these vaccines. We also saw important research that was being done, especially in European and Asian countries like Japan, for instance, where MMR vaccines were discontinued entirely. So the thought was that by discontinuing these vaccinations, we should see a slowing or a decrease in the incidence of autism. But to the contrary, these kinds of public health studies actually showed that even when you remove thimerosal from MMR vaccines, or as in the case of Japan, when you discontinued MMR vaccines entirely, we still saw this significant increase in the rate of autism. So there have been quite a few studies done since the original Lancet paper was published, that suggest that there is no clear evidence of an association between MMR vaccines or any other kind of vaccine that children are administered early in life and the incidence of autism. So to summarize, there's a lot that we know about what the causes of autism are, but at this point, there's still a lot of work to do, both to replicate and to better understand what these factors are. So with any of the disorders that we might be reviewing as part of Chapter 14, we're going to see that there are, in fact, genetic bases for this disorder, but we still don't know what specific genes are most responsible. We're seeing evidence that there are going to be neural bases for the disorder, and we really believe that autism is a neurodevelopmental disorder, but we're still not 100% clear on what the structural features and functional features of the brain of a child with autism include. We also know that there's important risk factors that might be more environmental or psychosocial in nature. For instance, the age at which a mother conceives that child. Some of the illnesses or complications of pregnancy have been related. But in general, all of these research findings that deal with the causes and risk factors of autism are very preliminary and are going to require a great deal more study before we have a more definitive picture of what the causes and risks of autism are. All right, now what I want to do is switch for the remainder of today's lecture and talk about ADHD, attention deficit hyperactivity. And what I'd like you to do here too is to start by watching this short video on what the core features of ADHD are, what are the major symptom domains, and a little bit of what it's like to work with children with ADHD. I think it'll give you a good flavor as I start to dive into what the science of ADHD tells us about this disorder of childhood. All right, let's start by first considering, how frequent ADHD is. In fact, ADHD is the most common disorder of childhood. Depending on the study, estimates range from as low as 6% to as high as 12%. And we know that in general, about 6 to 8% of all children have ADHD as a primary diagnosis. So what is ADHD? What is attention deficit hyperactivity? What are the core symptom domains that are described in DSM-5? We generally think of ADHD and the symptoms of ADHD as falling into one of three different categories or areas. The first is attention, so problems with attention and attention regulation. The second is problems with behavioral regulation, in particular hyperactivity. And the third is problems with impulsivity. The inability to inhibit behavior, especially behavior that might be disruptive or counterproductive. These are the core symptoms, or what we call the ADHD triad. Now let me take a look at each of these a little bit more carefully. So what are the core features of attention deficit hyperactivity? Well, as I've said, the first are symptoms of inattention. Children with ADHD show a wide variety of attentional difficulties, from inability to pay attention in school to adults, especially adults that are giving them instruction, the inability to sustain attention, the inability to resist distraction, the ability to stay engaged in what you're supposed to be focusing on is very difficult for kids, primarily because they're so vulnerable or prone to being distracted by other potentially more appealing things. So easily distracted is a core feature of the attentional problems that we see in ADHD. We also see problems in hyperactivity, and by this I mean problems in terms of inhibiting behavior, things like fidgetiness, fidgety hands and feet, inability to stay in their seat. When children are in class in particular, this is a particular challenge for them, very difficult for children with ADHD to stay in their seats. We also see this hyperactivity expressing itself out in places where children should be or would be expected to be able to move around. So for kids who are dealing with hyperactive symptoms, one of the things that we often see is they're sort of running around and can't seem to stop, can't seem to regulate themselves. It's a kind of restlessness that makes it difficult for these children to engage in behaviors that might be more pro-social or socially engaged. We also see core symptoms in the area of impulsivity. In class, this might be children who can't raise their hand or wait their turn to be called on, but rather are blurting out answers. So this inability to inhibit the desire to speak or the desire to act, these are core features also of ADHD. So this triad of attentional difficulty, hyperactivity, and problems with impulsivity are the core of what makes up ADHD. Now, in terms of the actual ADHD diagnosis, as described in DSM-5, not all children will have deficits in all of these three areas. Rather, we'll see combinations of problems, and DSM-5 talks about three primary types of ADHD. We have ADHD, which is primarily of an inattentive type, and these are children who historically would have been called children with attention deficits. But now we see that these children have primarily attentional problems, but they may also show at a lesser degree or a lesser frequency problems with hyperactivity or impulsivity. For these children, ADHD that's a predominantly of the inattentive type suggests that these children are really dealing with issues of attention. We have, as another type, predominantly hyperactive and impulsive kind of ADHD. For these children, the struggle with attention and attention regulation is not as pronounced as the problems that they're dealing with in terms of hyperactivity and impulsivity. We see this kind of ADHD much less frequently than we do the inattentive type. But in fact, the most common diagnosis for ADHD is what we call the ADHD combined type. And this is really children who are dealing with problems in all three of the areas that I reviewed. It's the most common form of diagnosis in childhood, and it's the most common form of ADHD, the combined type. So the developmental trajectory of ADHD, or for children with ADHD, is a very interesting one. As with autism, I made the case earlier that we usually see it clearly or most clearly by around 3 or 4 years of age, even though parents would suspect that it was present earlier. We generally see problems with behavioral regulation very early on in children. So by around 3 or 4 years of age, we generally begin to see children's hyperactivity and problems with inhibition, children who are very accident prone. And it isn't until children are transitioned into more structured environments like daycare or preschool, or certainly by the time they reach kindergarten, that we actually begin to see problems that they might be having in inattention. So early signs of ADHD might really be problems with inhibition and hyperactivity, but by the time children reach a school age of 6 to 7, that's when you might see problems with attention begin to emerge. But one of the things that's also characteristic of ADHD is that it tends to be highly correlated with other kinds of problems too. So by the time children get into their school years, so between the ages of 6 and 12, you start to see problems with aggression and oppositionality begin to emerge. The bottom line for children with ADHD is that they tend to rub lots of people the wrong way. They can't control their hyperactivity, they can't control their impulsiveness. That can be very difficult for other people, both children and adults. And that can lead to defiance, it can lead to oppositionality, and can lead to conflict with others. So you can begin to see this progression from early on, a disorder that's defined primarily by attention and hyperactive and impulsivity problems, to a disorder that also now includes problems with aggression and social relationships. So as this next slide summarizes in this figure, what I'm talking about is what is called the heterotypic continuity of ADHD or other kinds of externalizing disorders. So early on, we might see in children primarily problems that are defined by attention, hyperactive, and impulsive symptomatology. But as children progress and move through their school years, we can see that these early problems with attention and impulsivity might lead to problems with oppositionality and early conduct problems. And for certain children who are beginning to show peer and social relationship problems, primarily because of ADHD, this may be an early predictor of later problems, for instance, problems with substance abuse and the early onset of substance use. Okay, turning for a few minutes now, let's look at the epidemiology. I've given you a flavor of the fact that ADHD is the most common disorder of childhood. But how prevalent is it? Again, we've, depending on the study, have seen that repeatedly somewhere between 6 to 10% of all children will be diagnosed with ADHD. But again, it really depends on often who you ask. Parents tend to see it more frequently than teachers. And most parents and or teachers or caregivers begin to see it somewhere around age 3 or 4. We also know, in the way I was just describing the heterotypic developmental course of ADHD, that ADHD shows a high degree of comorbidity with other kinds of disorders, both of childhood and later on. So we often see children with ADHD as having a high degree of comorbidity with other kinds of oppositionality and conduct problems. We also see an increased likelihood of substance use and abuse by the time children reach adolescence. And not surprisingly, we also see a high degree of comorbidity with what we call internalizing problems, including anxiety and depression. In terms of gender statistics, like autism, ADHD tends to be more common in boys than girls. And it used to be thought that ADHD was largely a disorder of boys, but over the course of the last couple of decades, we've done a better job of understanding the way in which girls and women might experience and express ADHD. But still, the preponderance of cases tend to be boys at a ratio of about 3 to 1. In terms of the kinds of ADHD or the subtypes of ADHD that we might see, we tend to see girls displaying less of the hyperactive and impulsive features of ADHD and more of the inattentive, the sort of the daydreamy, spacey kinds of symptoms that often are used to describe certain children, tend to be more characteristic of boys, of girls. Looking now at this slide, we see a little bit more information about the comorbidity. So again, about 6 to 10% of all kids have ADHD, but of those, probably 80 to 90% of those kids are going to have at least another kind of disorder. And probably 2/3 of all children with ADHD will be diagnosed with multiple diagnoses, so 2 to 3 additional diagnoses. So really one of the things that I want you to think about is, even though this disorder may be very focused in terms of attentional features and hyperactive and impulsive problems, it tends to set the stage and increase the likelihood that children are going to develop a host of other kinds of diagnosable problems. All right, let's turn now and think about some of the causal or etiologic factors of ADHD. Again, I want to review some of the biological, social, and contextual factors that we know have been implicated in the developmental progression of ADHD. One of the things that we're fairly definitive about right now is that ADHD is a disorder that does not arise primarily or purely by social factors. There's clearly important underlying biological characteristics, but as is the case with most forms of psychopathology, both in children and adults, what we're trying to understand is how do these underlying biological vulnerabilities or susceptibilities interact with specific aspects of children's environment. So we know that while social factors alone are probably not going to contribute to ADHD, it's the interaction between biological characteristics and environmental characteristics that are going to be the most prognostic. All right, so thinking a little bit about biology, let's think a little bit about some of the prenatal factors. There's been a fair amount of work that's shown that some of the brain features that are associated with ADHD might take shape prenatally because of certain kinds of risk factors that are present prenatally. So one of the things that we know is that smoking, maternal smoking during pregnancy, is highly related to increased likelihoods of developing ADHD, in particular the impulsive and hyperactive kind. We also know that children who are born prematurely or who have low birth weight at birth are also at increased likelihood of developing ADHD. So anything that might go on prenatally that increases the risk of prematurity or low birth weight have been shown to be related to ADHD. One of the things that we know is that all of these prenatal factors seem to operate on areas of the brain that are involved in the regulation of dopamine, which is a neurotransmitter that's critical to the regulation of behavior. So one of the things we understand about the prenatal factors or the prenatal environment is that the risks that occur there tend to operate on areas of the brain that are critical to the regulation of behavior as well as the regulation of attention. In terms of genetics, we also know through twin behavioral genetic studies of twins and adoption studies that there's a degree of heritability, or a fairly high degree of heritability, among families where ADHD tends to be present. So when there's first and second degree relatives who have shown or have had problems with ADHD, there's an increased likelihood that the offspring of those parents are going to have ADHD themselves. Okay, knowing that there's a genetic basis for ADHD is one thing, but knowing what specific genes are implicated is a different thing entirely. And we're very early on in our work to identify what those particular or specific candidate genes are. At this point, it's safe to say that what we do know about the genetics of ADHD is that there are many genes involved, each is likely making small contributions, and that ultimately it's going to be combinations or networks of genes that are interacting together with certain kinds of environmental characteristics or features to predict the onset and course of ADHD. So again, the search for genetic by environment interactions is really where we are in our understanding of what the etiology of ADHD is. As I said a minute ago, in terms of prenatal factors and what we know to be what's most affected in terms of, say, exposure to smoke prenatally, we know that genes that are involved in the regulation of dopamine, what we call catecholamine genes, seem to be, in many studies, implicated in ADHD. So there are a variety of different dopaminergic genes, but many of these are involved in the regulation of behavior, including the regulation of attention. And so we've seen in molecular genetic studies that different kinds of dopaminergic characteristics at a genetic level have been linked to ADHD in children. Moving up from the genetic level to other areas of brain and brain functioning, there's been a number of studies that have established that there are a variety of areas of the brain that might be implicated in ADHD etiology or the cause of ADHD. So we've seen studies that implicate what we call the frontal or prefrontal cortex of the brain. There seem to be a variety of differences in the brains of children in the prefrontal region who do and don't have ADHD, and probably the most pronounced difference is one of size. And children with ADHD often show smaller prefrontal cortex areas than children who are typically developing. But also we know that children with ADHD generally will catch up in terms of the size of that prenatal area, but it may take a while, and by that point some of the problems associated with ADHD, in particular failure in school, difficulties with peers, may already have traction, and even though the brain areas that are implicated might be catching up, there's these secondary effects that are problematic. We also see deficits in brain areas that we know to be involved in what we call executive functioning, also again prefrontal areas. So, and by executive functioning I mean the ability to direct and regulate attention, the ability to direct and regulate emotion. So we know that areas of the brain that are involved in executive functioning have been implicated. So there's a variety of studies that have shown interesting features of the brains of children with ADHD versus those without. And we know that going forward that this is going to be a hot area for trying to understand maybe not just the causal factors that lead to ADHD, but exactly how ADHD operates in the brain. So moving from biology to psychological and cognitive and psychological models of ADHD, there's been a lot of work done to suggest that there may be important motivational deficits in children with ADHD. In particular, two neuropsychological models have been given a lot of support. One emphasizes that children with ADHD have very unusual sensitivities to both reward and to punishment. In general, children with ADHD seem to be somewhat immune to punishment. So, when it's difficult for them to pay attention or when they act impulsively, when parents or teachers try to redirect and direct them, sometimes using punishment, sometimes using reinforcements and rewards, children with ADHD seem to be unusually immune or insensitive to this kind of feedback. And we think that this may be interfering with their ability to learn and to develop certain kinds of regulatory strategies, as well as to know the difference between right and wrong and how to inhibit behavior. A contrasting model is a model that suggests that children with ADHD may have an aversion to waiting. And a really easy way to see this is that if you put in front of a child with ADHD a very salient reward, it's very difficult for him or her to be able to wait in order to get that reward, and they'll impulsively need that now. So this leads to what we call a failure in the ability to delay gratification. It's this aversion to waiting that might be interfering with their ability to manage attention and to regulate behavior. Two other cognitive neuropsychological models emphasize both arousal as well as executive functions and how they control attention. Arousal models suggest that children with ADHD may have very slowed cognitive tempo. So in contrast to this idea that these children are hyperactive and overly stimulated, arousal models suggest that those areas of the brain that are critical to regulating attention and behavior are not actively involved, or not operating at a fast enough tempo to regulate those behavioral areas. So consequently, these children show problems with attention and problems with their control of behavior. Executive functioning models suggest that there may be deficits in some of these higher ordered skills and areas of the brain that are critical to attention regulation and the management of behavior. So brain areas that are involved in planning and organization, the ability to establish or monitor behavior, as well as prefrontal systems that are involved in inhibiting behavior and inhibiting responses. So these cognitive models are pointing to different neurobiological areas in terms of how they might be playing a role in ADHD. And moving beyond both biological factors and cognitive neuropsychological factors to other environmental characteristics, there's been a lot of work that suggested that exposure to early toxins or toxins early in life may be an important factor. As I've said already, exposure to prenatal nicotine and tobacco has been shown to be highly prognostic or predictive of ADHD. We also know that exposure to certain other kinds of toxins may be implicated. For a number of years, there was some thought that there might be aspects of children's diets, in particular allergens and factors that might be contributing to allergies, that are related to ADHD, but there's been very little research that supports this. In fact, some research suggests that there are no causal relationships between the characteristics, especially food additives in children's diets, and ADHD. Rather, what we know to be important is the prenatal nutrition of a mother seems to be implicated. Women who have healthier prenatal diets tend to have children who develop brain areas more typically and at rates that we would expect. One area that has received a lot of attention is exposure to lead. For many years, when lead was not regulated by the FDA, paints, furniture, products had high concentrations of lead, and these seem to be highly correlated with certain kinds of ADHD-type symptomatology. So one of the things that we've come to understand is that exposure to lead may have an impact on areas of the brain that are involved in regulation of, in particular, dopaminergic kinds of systems. So lead may be a risk factor for ADHD. All right, so to summarize today, I've reviewed a little bit of what DSM-5 provides in terms of how we can understand what childhood disorders are and what are some of the characteristics of the DSM that are sensitive to developmental issues, both within disorders of childhood but also disorders that are characteristic across the lifespan. And I spent a little bit of time reviewing the core characteristics of autism and ADHD, as well as some of the epidemiology and etiologic models of autism and ADHD. And as I said at the outset, these are just two disorders of childhood, and there are many others that we could talk about, time permitting. For instance, oppositionality and conduct disorder are also prevalent during childhood, as well as eating pathology that tends to have its emergence in adolescence. These are also characteristic of childhood psychopathology, but are beyond the scope of what I want to cover today. The next lecture, when I resume, is going to be focusing on disorders of adulthood.